Okay, good morning everyone. So after a week, again we are here to have another class that is on most important topic that remains unaddressed and always remain a challenge to which medication we should use for a patient who is suffering or who is having neuropathic pain. So today's class will be taken by Krishnapriya. Krishnapriya was our brilliant MD student, and from Krishnapriya we have set in an example of moving from one place to another, and she has moved to KMC Manipal as a senior resident of KMC Manipal, and I am very happy that she is fortunate that now she will learn from Naveen Salins and her team the new concept or new things from in what exactly and what extra she will be. I'm sure that she will be learning lot of new things and lot of new concepts of palliative medicine from Naveen and their team members. She was always a sincere student. That's what I have told Naveen, and it is a mutual this thing that KMC Manipal is lucky, and even Krishnapriya is very, very lucky. I have told her that you are a most luckiest person in area of palliative medicine. And this class will be moderated by Saurabh. Saurabh was another brilliant student. Was a brilliant student of ours. Now he is faculty of our department. And you know, whenever we talk about a subject of anything which is related to area of palliative medicine or in any area, he has lots and lots of knowledge of everything, all the concepts of human body and the treatment part. So we are everyone is looking forward, Saurabh and KP, which medicine they should be choosing for, and what are the adjuvants medication for neuropathic pain management. So we please start. Thank you very much.
Thank you, ma'am.
Krishnapriya, please start. The topic today, we've been given groups of drugs. So we'll be dealing with each group of drugs for neuropathic pain, its basic pharmacology and the agents. And at the end of each group, we'll be showing the current clinical evidence which is available. Where does that group stand in the neuropathic pain management? And at the end, after discussion of all the drug groups, we'll be presenting the neuropathic pain ladder and how to stepwise use each of the analgesics discussed. So, KP, please start.
Thank you, sir. Today's topic is Adjuvant Analgesics Part 1, that is Adjuvant Analgesics used for neuropathic pain. So the contents that we'll be discussing is neuropathic pain, antidepressants, that is TCNs, SNRIs, anti-epileptics, NMDA receptor antagonist, corticosteroids, anti-arrhythmics, potassium channel openers, drugs causing activation of Gaba inhibitory and glutamate excitatory system, and neuropathic pain ladder. So coming to the epidemiology, according to 2020 CDC analysis of data, 20.5% of adults worldwide had chronic pain. In that, 10% of the adults had high impact chronic pain with work limitations. Prevalence of neuropathic pain may occur as many as 10% of the general population, and more frequent in women over the age of 50 years, and most commonly affects the lower back and lower limbs, neck and upper limbs. Lumbar and cervical painful radiculopathies are probably the most frequent cause of chronic neuropathic pain. So the IASP definition of neuropathic pain is that the pain that arises as a direct consequence of a lesion or diseases that affects the somatosensory system. So the classification of pain is both nociceptive and neuropathic. In nociceptive, pain could be somatic or visceral, and in somatic, it could be superficial or deep. And in neuropathic pain, it could be mononeuropathies, polyneuropathies, deafferentation pain, central pain, or sympathetically maintained pain. So coming to the pathogenesis, we could see that whenever there is a nerve injury or a neuronal injury in the peripheral nervous system, there is a release of chemical milieu that involves the inflammatory factors, neurotransmitters from the injured neuron. These chemicals disturb the sodium-potassium balance within the damaged sensory neurons and around the neurons. And this disturbance raises these neurons' resting membrane potential, making them much more likely to depolarize and trigger respective sensations that they encode. So this is the reason for the cause of hyperalgesia. That is, the same pain stimulus may trigger a more nociceptive depolarization, causing a worse pain in response to a normal painful stimuli. It can also affect the unmyelinated C fibers, myelinated A delta fibers, and myelinated A beta fibers. So we could see the various presentation of neuropathic pain. The patient may complain of a gnawing pain or a burning sensation or shooting pain, a lancing pain, or allodynia. That is pain in response to a normal non-painful stimulus. These are due to the injury to the various C fibers, A delta fibers, and A beta fibers. So coming to the management of neuropathic pain, we will be discussing adjuvant analgesics of neuropathic pain today. So what is an adjuvant analgesics? These are the medications whose primary indication is not the main management of pain, but have analgesic properties which are given in addition to opioids for pain management. So these are also called as co-analgesics. So the cancer is a multifactorial and often involves inflammatory, nociceptive, and neuropathic pain subtypes. And the recent WHO categorizes these analgesics as non-opioids, opioids, co-analgesics, that is antidepressants, anticonvulsants, ketamine, local anesthetics, or adjuvants, that is steroids, muscle relaxants, and bisphosphonates. So the classification of analgesics there are various classification of adjuvant analgesics. Based on the clinical efficiency, we can see it could be a multi-purpose adjuvant analgesics like an antidepressants or corticosteroids, or an adjuvant analgesics for neuropathic pain, which we'll be discussing today. And the adjuvant analgesia is used for bone pain or bowel obstruction or musculoskeletal pain. That is based on the clinical efficiency. And another classification is based on the mechanism of pain. That is, it's nociceptive or neurogenic. Accordingly, the examples of the pharmacological management will vary. And another classification is based on the molecular target, the mechanism and the molecular target. That is, if it is causing any peripheral sensitization, or it is because of a sympathetically mediated pain or a central sensitization, accordingly, the various drugs that we use may vary. Pharmacological agents affect pain differently. So there is an ascending pain transmission and a facilitation of a descending pain modulation. So the drugs which inhibit ascending pain transmission are acetaminophen, NSAIDs, lidocaine, caspacin, menthol, opioids, and cannabinoids. And that facilitate the descending pain modulation are anti-epileptics, antidepressants, cannabinoids, and ketamine. So we can start from the first category of drugs, that is antidepressant in neuropathic pain disorder. Antidepressants are one of the oldest pharmacological treatment for chronic pain, and they have been subjected to many RCT trials for chronic non-cancer pain, probably due to its effect on insomnia, anxiety, and depression. 80% of neuropathic pain RCTs have been done in painful diabetic neuropathy and post-herpetic neuralgia. The analgesia occurred via pain-inhibiting systems that descend from the brainstem onto the dorsal horn of spinal cord and involves an endorphin link from the periaqueductal gray area to medullary raphe. This is the inhibiting pathway, the mechanism of action of antidepressants. So in detail, we can see that tricyclic antidepressants, the mechanism of action of tricyclic antidepressants is that they inhibit the reuptake of biogenic amines. That is mainly the norepinephrine and serotonin. So basically the tricyclic antidepressants works by enhancing the inhibition from the brainstem to the spinal cord. So these are some of the antidepressants that we use. That is most commonly tricyclic antidepressant that we use is amitriptyline. From the therapeutic range for pain is 10 to 150 milligram. And we can see that it has effect on norepinephrine and serotonin. And the side effects most commonly are sedation, orthostatic hypotension, weight gain, dry mouth, and constipation. And the other group of drug is SNRIs, serotonin and norepinephrine reuptake inhibitors. Then the drugs included in that is venlafaxine and duloxetine. So we could see that they come from the therapeutic range of 37.5 to 225 milligram and duloxetine 60 to 120 milligram. And compared to the tricyclic antidepressants, the sedation, orthostatic hypotension, weight gain are comparatively less for serotonin and norepinephrine reuptake inhibitors. But the GI distress is very high. And another newer SNRI drug is milnacipran, which has anti-allogenic and anti-hyperalgesic property and is used in fibromyalgia, and it also potentiates the effect of tramadol. The starting dose is 25 milligram daily and can be increased up to 200 OD or BD. So let us see what the difference and comparison between TCA and SNRI. So the mechanism of action we have discussed before. The side effect is the serious cardiotoxicity is one of the side effects of TCA, and other side effects we have discussed. And the most common side effect of SNRI is nausea. So it is TCAs are contraindicated in heart failure, cardiac conduction block, and epilepsy. Venlafaxine is contraindicated in high blood pressure, renal, hepatic insufficiency. In duloxetine is contraindicated in hepatic insufficiency. So the daily dosing could be 25 milligram per day, and in elderly we have to reduce the dose, that is 10 milligram per day. Duloxetine we can start from 30 milligram once daily and raise up to 120 milligram per day, and venlafaxine we can start from 37.5 milligram. The maximum dose is 5 to 150 milligram daily, and for SNRIs is 150 to 225. Other antidepressants are SSRIs, also can be used in neuropathic pain. So in some studies shows the use of paroxetine, citalopram, fluoxamine in diabetic neuropathy and somatoform disorders, as well as in fibromyalgia. Bupropion can be used in neuropathic pain and fatigue from a starting dose of 100 to 150 milligram per day and can be increased to 300 to 450 per day. But the side effects are insomnia, nausea, headache, rash, agitation, excitement, decreased threshold, and sexual dysfunction. So this is one of the study which shows that duloxetine in the management of chemotherapy-induced peripheral neuropathy. So the individuals receiving duloxetine in initial treatment, that is from the first 1 to 5 weeks, reported a larger mean decrease in average pain compared to placebo-treated patients, and 59% of the duloxetine-treated patients showed improvement than compared to a 38% of a placebo-treated patients. And the conclusion was among patients with painful CIPN, the use of duloxetine compared with placebo for 5 weeks resulted in a greater pain reduction. So the updated 2020 guidelines from the American Society of Clinical Oncology suggest that duloxetine for an initial treatment of painful CIPN, and they did not limit this recommendation to taxane or platinum-related neuropathy. Another use of duloxetine for treatment of painful neuropathy or chronic pain or fibromyalgia. A study was done which included 18 trials, which included around 6,407 participants, in which 4 categories, that is diabetic neuropathy, fibromyalgia, depression and painful physical symptoms, and central neuropathic pain. These were compared, and it showed that duloxetine at a dose of 60 milligram daily is effective in treating painful peripheral diabetic neuropathy in short term, that is more than 50% pain reduction at 12 weeks, and duloxetine at 60 milligram daily is also effective for fibromyalgia over 12 weeks and over 28 weeks for painful physical symptoms with depression. Coming to the next category of drugs is anticonvulsants. Historically, carbamazepine is used as early as 1962 for the treatment of trigeminal neuralgia. Other group of drugs are gabapentinoids, that is gabapentin and pregabalin, that are anticonvulsants that have been shown to be effective for neuropathic pain as well as for fibromyalgia. The mechanism of action is the sustained repetitive firing of neurons by promoting inactivated state of voltage gated activated sodium channels. They also enhance the Gaba, that is the inhibitory mediated synaptic inhibition, and either by presynaptic or postsynaptic action, and inhibition of voltage gated calcium channels responsible for T-type calcium currents. So the most commonly used anticonvulsants in various types of neuropathy are in post-herpetic neuralgia. Gabapentin, pregabalin can be used. In diabetic neuropathy, carbamazepine is preferred. In HIV-associated neuropathy, lamotrigine can be tried. And in trigeminal neuralgia, carbamazepine is an FDA-approved treatment for trigeminal neuralgia. And in central post-stroke pain, lamotrigine can be tried. So let us compare the most commonly used drug, that is gabapentin and pregabalin. Gabapentin and pregabalin are thought to exert their analgesic action mostly via modulation of the alpha-2 delta protein of N-type calcium channels. So gabapentin also acts as an NMDA receptors, protein kinase C, and inflammatory cytokines. And gabapentin and pregabalin are both minimally bound to the proteins and are not metabolized by the liver, and they are thereby devoid of pharmacokinetic drug-drug interaction. The drug is excreted unchanged in urine, and the plasma clearance is linearly related to creatinine clearance, and the dosage is readily adjusted based on renal function. So coming to the mechanism of action, we can see that pregabalin prevents the activation of voltage-gated calcium channels. Thus, all the pathways that is leading to pain, that is increased calcium influx, increased glutamate release, NMDA activation, the release of inflammatory markers, everything will be reduced when this voltage gated calcium channel is blocked by the action of pregabalin. So here also we can see how the calcium currents affects the pain, and the blockage of the same can decrease the pain sensation. So the comparison of gabapentin has a saturable absorption process, of which makes its availability lower at higher doses. That is 35% for 600 milligram 3 times daily versus 60% for a single 300 milligram dose. So requires administration 3 to 4 times daily. But the newer preparations like gabapentin N-carbil is an actively transported prodrug of gabapentin that provides sustained dose proportional exposure to gabapentin, allowing twice daily administration. But in the case of pregabalin, it has a significant advantage over gabapentin. That is because it does not require active transporters to be absorbed. So therefore, it has a linear pharmacokinetics. This makes dose titration easier and allows twice daily dosing. So gabapentin is effective in the treatment of CRPS, complex regional pain syndrome, HIV neuropathy, multiple sclerosis, and cancer-related neuropathic pain. And pregabalin has a faster onset of action than gabapentin. It can be used in fibromyalgia, irritable bowel syndrome, chronic pancreatitis, painful peripheral neuropathy in hemodialysis patient. And it is the only FDA-approved medication for the treatment of neuropathic pain associated with spinal cord injury. So these are the dose adjustment that we have to follow, because we have discussed that pregabalin and gabapentin are excreted unchanged in urine. So creatinine clearance is important in the dose adjustment of pregabalin and gabapentin. So this table can be followed for the dose adjustment. Similarly, for gabapentin, according to the creatinine clearance, the dose adjustment has to be done. So other anticonvulsants that we have discussed is gabapentin and pregabalin. Carbamazepine is another drug, helps in the blockade of voltage-gated sodium channels and decrease the excitability. The dose for neuropathic pain is 100 to 200 milligram QID or BD. And the usual effective dose is 300 to 800 milligram BID, but it contains a lot of precautions and contraindications, because it cannot be used along with MAVO inhibitors, or in case of any cardiac dysfunction, hepatic or renal dysfunction, and potentially fatal blood dyscrasias. So we have to monitor the CBC, platelets, renal and liver functions before starting carbamazepine. And it can also cause potential fatal severe dermatological diseases like Stephen-Johnson syndrome. So the other is oxcarbamazepine, almost similar to carbamazepine. Other two drugs are lamotrigine and topiramate, which acts in the same pathway, that is blockade of voltage-gated sodium channels, decrease the glutaminergic neurotransmission, and increase the GABA activity. So similarly, these drugs can also be tried in case of neuropathic pain. The third category is ketamine, that is an NMDA receptor antagonist. The key receptors involved in the activation of central pain sensitization process are the glutamate receptors, such as NMDA receptors. So ketamine is an NMDA receptor antagonist, which can also be used for chronic pain. So it can be used in complex regional pain syndrome, deafferentation pain, ischemic limb pain, phantom limb pain, fibromyalgia, central headache, cancer pain, and other neuropathic conditions. The mechanism of action is it's a non-competitive NMDA antagonist, binds to the phencyclin site when the receptor is in the open state, and inhibits the NMDA receptor mediated response in the spinal cord and thalamus, and also inhibit the wind-up phenomena, that is a frequency dependent increase in the excitability of spinal cord neurons evoked by electrical stimulation of C fibers. So typically ketamine is given IV, but can be given IM, oral, epidural, rectal, intrathecal, intra-articular, topical, intranasal, or sublingual. Rapidly passes through the blood-brain barrier. Peak plasma concentration is reached in 1 minute, and IV half-life is 2 to 3 hours. Plasma concentration of ketamine is 30 nanogram per ml and sufficient to obtain a decrease in pain and opioid consumption after surgery. Given orally, ketamine has a bioavailability of 20% with an onset of action of 30 minutes, and its analgesic effect duration is approximately 3 hours when given orally. Its bioavailability is 93% when given intramuscularly with an onset of action of 5 minutes. So ketamine in the management of chronic pain. So an evidence-based study show that we should ensure that there is no contraindication to the use of ketamine. Educate the patient regarding the potential side effect and obtain fully informed consent. And perform a fully monitored placebo-controlled IV trial of ketamine to assess therapeutic benefit. So the available data suggests 0.25 to 0.5 milligram per kg given slowly over 30 minutes with pain assessment before and after administration. After a good therapeutic response from the systemic administration suggests a greater likelihood of benefit from oral dosing. So comments oral ketamine 0.5 milligram per kg taken immediately before going to bed to minimize the likelihood of side effects, and increase the dose by 0.5 milligram per kg as tolerated until pain relief is obtained. Or tolerable side effects occur, and the mean effective dose from the literature is 200 nanogram per day, although there is a wide variation. For severe acute or chronic episodes of neuropathic pain, administer ketamine by continuous infusion, IV or subcutaneous, at the rate of 0.14 to 0.4 milligram per kg per hour. The side effects are more than 10% we can see emergence reaction or hypertension, increased cardiac output, increased ICP, tachycardia, tonic-clonic seizures, visual hallucination, and vivid dreams. In 1 to 10% we can see bradycardia, diplopia, hypotension, increased IOP, injection site pain, and nystagmus. And very unlikely side effects are anaphylaxis, cardiac arrhythmia, or depressed cough reflex, fasciculations, hypersalivation, etc. So Cochrane review of ketamine as an adjuvant to opioids for cancer pain review show that there is 2 small studies which reported an addition of ketamine to morphine, reduced pain intensity and morphine requirements. But the third study which used high doses of ketamine reported no clinical benefit of adding ketamine to different opioids. An increased dose of ketamine is in some patients cause side effects such as hallucination. And the study which examined high doses of ketamine reported 2 serious adverse effects, and also 2 out of 3 studies reported a reduction in pain. This could be due to such a small study. The next category.
Just go to the previous slide. This review came in 2017, and the 3 studies which were included, 2 had a patient numbers of only less than 20 and 50, and 1 study which showed more adverse effect had numbers of more than 195 patients. So the pooled evidence still does not favor ketamine much, and it is in the step ladder you will see it is only for rescue therapy and not a first line agent.
The next category is corticosteroids. So steroids are classified into corticosteroids, androgens, progestrogens, and estrogens. And corticosteroids could be glucocorticoids or mineralocorticoids. So the regulation of cortisol secretion from the hypothalamus corticotrophin releasing hormone activate the anterior pituitary for the release of. Then it releases adrenocorticotropic hormone, which stimulates the adrenal cortex to release the cortisol. So then similarly, cortisol exerts its negative feedback on hypothalamus and anterior pituitary. So the endogenous and synthetic steroids cause negative feedback of the hypothalamus pituitary axis, and it is a dose dependent and time dependent process. And the circadian rhythm and diurnal variation of cortisol is secreted variation, that is cortisol is secreted in an episodic manner, and frequency of pulses follows a circadian rhythm and is dependent on both daytime and sleep, both day, night and sleep wake pattern. Levels are highest in the morning on waking and lowest in the middle of evening. Maximal cortisol level occurs at 4 to 6 a.m. and lower at 4 to 8 p.m. Comparison of systemic glucocorticoid preparations. So we can see there are short-acting glucocorticoids, intermediate-acting glucocorticoids, and long-acting glucocorticoids. So we could see that the anti-inflammatory activity of relative to the hydrocortisone, we could see that the maximum anti-inflammatory action is for dexamethasone and betamethasone compared to other glucocorticoids, and fludrocortisone, which is a mineralocorticoid, does not exert any anti-inflammatory property. So the pharmacology and physiology, anti-inflammatory properties are due to the inhibitory effect on the action of phospholipase E2. And the mechanism of action is decreased production of inflammatory mediators such as leukotrienes, prostaglandins, and which halt the inflammatory cascade and reduce vascular permeability. Mineralocorticoid properties of steroids may lead to higher risk of sodium excess, potassium loss, and water retention. Cortisone and hydrocortisone are rarely used for long-term anti-inflammatory therapy. So coming to the role of corticosteroids in the treatment of pain in cancer patients. The most often prescribed corticosteroid for
Just
pain...
Just a second. The corticosteroids, I would like to reinforce that they are very attractive agents, but they've been classified as multi-purpose drugs. They are used, they have efficacy in many types of pain. Neuropathic pain is just one of them. They are mainly used in capsular stretch pain, duct obstruction, or anti-inflammatory effect. Even in bone pain, they are effective. So their role in neuropathic pain, they have to be carefully selected and used. The duration of usage and selection of agent is very important, and we'll show the evidence. What does it say? Go on.
The role of corticosteroids in the treatment of pain in cancer patients. The most often prescribed corticosteroid for pain management is dexamethasone. Dexamethasone upregulates angiotensin 1, a strong blood-brain barrier stabilizing factor, and it downregulates VEGF, a strong permeabilizing factor in astrocytes and pericytes. So what happens is dexamethasone also inhibits the interleukin-1 cytokines associated with macrophages, which helps in headache. That is, in glioblastoma patients, it improves the pain. And for long-acting dexamethasone causes less fluid retention and than other steroids because it has less mineralocorticoid effect. And given the present literature, a weak recommendation for the use of glucocorticoids in cancer patients with pain is indicated. So the variety of areas where for cancer pain where glucocorticoids can be used are including neuropathic pain and bone pain, and a pain associated with a stretch of an organ capsule caused by space-occupying lesion. In case of duct obstruction, pain from malignant bowel obstruction, pain caused by lymphedema, and headache caused by increased intracranial pressure. The Cochrane review of corticosteroids for the management of cancer-related pain in adults. It's a systematic review was to assess whether corticosteroids are effective in reducing cancer-related pain. So 15 randomized controlled trials and 1,926 enrolled participants were there. And the key result showed that there was significant pain relief was noted in some studies, but only for a short period of time. And this could be important for patients who have only short-term time to live. For a longer period of time, there were more of side effects of steroids and when they are used for a longer term. The adverse effects of corticosteroids are dermatological and appearance, that is skin thinning, weight gain, cushingoid features, acne, hirsutism, ophthalmologic features like posterior capsular cataract, exophthalmos. In cardiovascular system, it can cause fluid retention, hypertension, arrhythmias, and in gastrointestinal system, they can cause gastritis, peptic ulcer. In bone and muscle, osteoporosis, avascular necrosis, and neuropsychiatric, it can cause euphoria and insomnia in patients. And metabolic and endocrine, it can cause hyperglycemia. And immune system, it can cause increased risk of infection. Coming to the next category is anti-arrhythmic or sodium channel blocker. Whenever there is an injured primary afferent neuron,
just a moment. So to conclude, for corticosteroid, the drug of choice in general clinical practice does remain dexamethasone, and for a patient with short life expectancy, low dose corticosteroid is mostly used, but there is no general agreement on the dosage. So per day dose of 0.75 milligram to 1.5 milligram is usually suggested as a once daily dosing for a patient to be given continuous corticosteroid therapy. For a patient for a longer duration of life, which you expect, you have to give it in a short course as a pulse corticosteroid therapy and then taper down. But there is no agreement on the pulse of the dosage of the pulse. In malignant spinal cord compression, dexamethasone 10 times, 4 times a day, even that high dose is suggested. So it has to be tapered according to the patient profile and keeping in mind the comorbidities and the life expectancy of the patient.
The next category of drug is anti-arrhythmics, that is sodium channel blockers. Whenever there is an injured primary afferent neuron, show altered membrane properties such as hyperexcitability and exaggerated response to suprathreshold stimuli. So sodium channels are accumulated in the neuroma of a cut sensory nerve, where ectopic discharges may arise, and systemic lidocaine, a sodium channel blocker, has silenced this discharge. An oral anti-arrhythmic drug is mexiletine, which is also a sodium channel blocker. And a parenteral therapy, a brief intravenous use of lidocaine at the dose of 2 to 4 milligram per day infused over 20 to 30 minutes in a monitored setting, can be beneficial in the context of a very severe neuropathic pain because of a potential or rapid onset of relief. But the adverse effects could be according to the serum levels. There could be mild, moderate, and severe. In case of severe, it can cause confusion, loss of consciousness, muscle shivering, arrhythmia, and heart arrest. So we have discussed mexiletine. In some studies, it has shown improvement in neuropathic pain in the dose of 900 milligram compared to a placebo. And patients with diabetic neuropathy also, mexiletine 750 milligram per day versus placebo showed significant pain relief. Other anticonvulsants that block the voltage-gated sodium channel are carbamazepine, oxcarbamazepine, phenytoin, lamotrigine, valproic acid, and topiramate. So the role of lidocaine in prevention of central pain sensitization. That is, lidocaine attenuates the peripheral nociceptor sensitization and central hyperexcitability through its sodium channel blocking action. And lidocaine infusion is effective in relieving the mechanical allodynia and hyperalgesia associated with chronic neuropathic pain believed to occur through a central pain mechanism. And lidocaine has potent anti-inflammatory properties that are more potent than traditional anti-inflammatory drugs, which have fewer side effects, and lidocaine infusion has been shown to reduce the circulating inflammatory cytokines, thus preventing central sensitization and hyperalgesia. Topical lidocaine, 5% pliable patches can be used. Up to 3 patches applied once daily directly over the painful site, 12 hour on, 12 hour off, which is FDA approved. Recently published data indicate 4 patches, 18 hour up to 18 hours is safe, and efficacy demonstrated in 3 randomized controlled trials showed improvement in post-herpetic neuralgia. Drugs interactions and systemic side effects unlikely, and most common side effect is application site sensitivity. Clinically insignificant serum lidocaine levels were found with patch, and mechanical barrier of this application also reduced the allodynia. So topical versus transdermal. In topical, we use 5% patch. So there is peripheral tissue activity applied directly on the painful site, insignificant serum levels, and systemic side effects are unlikely. Another one is transdermal, that is fentanyl patches that we apply. That is systemic activity is there and applied away from the painful site, and serum levels are unnecessary and systemic side effects are there. The next category is the potassium channel opener, that is flupyridine, that is an aminopyridine that functions as a centrally acting non-opioid, non-NSAID, and non-steroidal analgesic.
Just wait, JP. So in sodium channel receptor drugs, it is very important to know that a topical lidocaine patch can be easily available and can easily be used in first-line drugs. The main monitoring for adverse effects is required when IV trial of intravenous lidocaine is given, but topical lidocaine patch can easily be used. And a very basic thing to know the difference between topical and transdermal preparation usage is also explained nicely there. Go on. Next.
Next category is potassium channel opener, that is flupyridine. It is an aminopyridine that functions as a centrally acting non-opioid, non-NSAID, non-steroidal analgesic. selective neuronal potassium channel opener that also has an NMDA receptor antagonistic property. So flupenitin activates G protein coupled inwardly rectifying potassium channels, and the resting membrane potential is stabilized and activation of cell membrane is inhibited. So we can see flupatin, it has 1/3 analgesic property of codeine, and it is a muscle relaxant and has no neuroprotective properties, used in fibromyalgia, and devoid of any addictive properties, negative psychological or motor function effects or effects on reproductive function. Drug tolerance does not develop in most of the cases, and availability is 90% oral and 70% rectal, and the dosage is more than 6 years. That is 50 milligram oral, that TDS to QID it can be given. Reduce the dose by 50% in patients with hepatic disease. Uses can be chronic pain and musculoskeletal pain. The next category is GABA receptor modulators, that is gamma aminobutyric acid receptor modulators include the benzodiazepine, which bind to the GABA A receptor subtype, and Baclofen, which binds to the GABA B receptor subtype. Benzodiazepine potentiate inhibitory effects of endogenous presynaptic GABA, and the only benzodiazepine that is used in neuropathic pain is Clonazepam. So the mechanism of action, so we can see the alpha, beta, and delta subunits of the GABA receptors. So the GABA inhibitory, which is an inhibitory neurotransmitter. So benzodiazepine binds to the GABA A receptors in brain. This enhances the GABA action on brain, causes chloride channel opening, and increases the influx into the cell, causes hyperpolarization and inhibition of brain. So clonazepam, as we can see, primarily it's used in epilepsy, tonic-clonic or partial seizures, in myoclonus, anxiety, panic disorder, or restless leg syndrome, but it has action on neuropathic pain also. Contraindication is acute or severe pulmonary insufficiency, sleep apnea, or severe liver disease or myasthenia gravis. Bioavailability is per oral is 100%, and subcutaneous onset of action is 5 to 10 minutes. Per oral, it is 20 to 60 minutes. And the peak plasma concentration is 1 to 4 hours. Adverse effects are fatigue, drowsiness, muscular incoordination, and hypotonia. In children, salivary hypersecretion and drooling can occur. Caution should be there in patients with respiratory disease, mild or moderate hepatic impairment, elderly, and patients with spinal or cerebellar ataxia, alcohol and abuse patients, and abrupt withdrawal may precipitate epilepsy in some patients. The dose recommendation for neuropathic pain is 500 microgram per oral, and divided doses, HS or OD, can be given to the patient. Another drug is Baclofen. Baclofen reduces the release of excitatory neurotransmitters by binding to the GABA B presynaptic receptors within the brainstem and dorsal horn of spinal cord and other CNS sites. Baclofen is effective for the treatment of spasticity and also has established efficacy in trigeminal neuralgia, neuropathic pain in cancer, and in also in treatment of spastic movement disorders, in multiple sclerosis, spasm, or hiccups. Low starting dose of 5 milligram BD or TDS, and increase in 3 days up to 20 milligram TDS can be given, and the T-half is 2 to 4 hours, and the bioavailability per oral is more than 90%. Topical cream, oral, intrathecal use using a pump implanted under the skin are the various routes of with which we can give Baclofen. According to the IASP guidelines, there are 4 steps in which we have to progress when we see a patient with neuropathic pain. So the step 1 is assess the pain and establish the diagnosis of neuropathic pain. And if uncertain about the diagnosis, refer to a pain specialist or neurologist. And establish and treat the cause of neuropathic pain and identify relevant comorbidities that the patient is having, like cardiac, renal, hepatic, depression, gait instability, that might be relieved or exacerbated by neuropathic treatment, or that might require dosage adjustment or additional monitoring of therapy. The step 2 is initiate for the disease-causing neuropathic pain. Treatment for the disease-causing neuropathic pain. A secondary amine, that is TCN or tryptylene desipramine, or an SSNRI, that is duloxetine or venlafaxine, or a calcium channel blocker that is Gabapentin or Pregabalin, and for the patients with localized peripheral neuropathy, topical lidocaine used alone or in combination with the first-line agent can be given, and opioid analgesics or tramadol may be used alone or in combination with the first-line therapy. The step 3 is reassess the pain and health-related quality of life frequently, and if substantial pain relief and tolerable adverse effects are there, then continue the treatment. If there is partial relief after an adequate trial, add one of the other four first-line medications, or if no or inadequate pain relief is there, change to first-line treatment. In the step 4, if trials of first-line medications alone or in combination fail, consider second and third-line medication or refer to a pain specialist or multidisciplinary pain center. So these are the first-line, second-line and third-line agents that we use, the drugs that we use in neuropathic pain ladder. The first-line drugs could be amitriptyline, pregabalin, duloxetine or lidocaine 5-patch. Second line is mainly opioids, tramadol. And third line could be baclofen, mexiletine, caspacin, or ketamine. So the take-home message is that neuropathic pain is highly debilitating, difficult to diagnose, and only partially responsive nearly to all treatment. So the first-line treatment could be TCS, gabapentinoids, SNRIs, topical lignocaine, and caspacin. And this could be trialed over an average of 4 to 6 weeks. And the second-line treatment could be, we can try with tramadol and combination therapy. And the third-line treatment could be interventional therapy, such as epidural injection, pulsed RFA, sympathetic blockade, and anesthesiolization. And fourth-line treatment, we can go with neurostimulation, that the patient should have a diagnosis of neuropathic pain of greater than 6 months duration and have a pain score of more than 5/10 and have failed to respond adequately to other therapies. So the summary of some of the commonly used adjuvants in combination and in separately and in combination, as a single agent, as in a combination therapy. These are the various drugs. Thank you.
Thank you, PP. Thank you very much. Thank you. Excellent presentation. Saurabh, would you like to summarize, and then we will take question and answer. There are very senior people are here, so we will listen their experience. Okay, go ahead, Saurabh.
Today we have discussed 5 major groups of drugs. So they are very commonly used in clinical practice, and there are some take-home points which I would like to reinforce from every group of drug. So in neuropathic pain, as a starting agent, gabapentinoids are a very attractive choice, and almost everyone has heard of them and used them. So we have to know that the pharmacokinetic profile difference between gabapentin and pregabalin, which states that pregabalin should be the first drug of choice to start the therapy because its dose titration is easier. But the evidence overall in literature regarding efficacy or superiority of pregabalin over gabapentin is equivocal. Pregabalin is not superior to gabapentin. This I'm saying because gabapentin is easily available and is cheaper, so it is still equivalent in efficacy to pregabalin as per literature, but pregabalin is easier to titrate in dose. Also, we have to keep in mind that even in 2020, FDA has given a label warning that gabapentinoids have an additive effect with opioids in respiratory depression. So we have to be very careful in prescribing these drugs in patients already taking opioids. For antidepressants, SNRIs, that is duloxetine, literature states that duloxetine is first drug of choice in starting a patient on neuropathic pain, especially for chemotherapy-induced neuropathic pain. And starting dose is 30 to 60 milligrams. And side effect profile is generally tolerable. And when starting with other SSRIs, we have to keep in mind the general side effect profile of the drug to start its use. And also antidepressants should be always given in low doses, gradually escalated in dose, and whenever stopping, they should be tapered and stopped and not abruptly stopped. This is a general clinical peril of it. And for steroids, I've already told they are multi-purpose agents. They are very attractive to be started, but we have to take care when to start, how to start, in what dose to start, and how much time to use. For the newer, also topical lidocaine patches should be used if available in general practice. And there are some queries regarding flupertine, which is a newer drug, and its effect is just being studied in various drugs. And if somebody is asked regarding fibromyalgia, so what I'll share a review article in the group. I'll share with Archana ma'am, and she can put up for the evidence of flupertine in various types of cancer pain and for in various pain syndromes. For fibromyalgia, there are only case series which have prescribed in doses of 200 to 300 milligram flupertine with positive effects. There is, I could not find any randomized control trial as such, but yes, the dose, the role is there. And for ketamine, yes, it is a very attractive drug for, especially for anesthetists, but its use has to be kept in, has to be closely monitored. And what in my clinical experience, Neetu has asked, we've used for 2 patients under Dr. Sushma as a burst therapy. That is, burst therapy with ketamine is patient with refractory pain. We give short burst, short duration of IV ketamine infusion. And we have to be very careful about its delirium, delusion, and other adverse effects. Also, anesthetic doses have to be avoided. It has always to be used in sub-anesthetic doses, keeping in mind the respiratory depression in anesthetic induction doses. That is there. Somebody is also asked regarding subcutaneous ketamine use. I have not used, I have only used IV ketamine. If somebody is used, they may put up in the chat box, or I'll search for the available preparations and I'll give it to Archana madam, and she can share with everyone. And other thing is that the pain ladder for neuropathic pain has been clearly described by IASP, and we have summarized it here. And all the agents can be used. First line agent has to be identified on basis of individual choice and clinical practice. And we have to stick to our therapies and go slow, escalate slowly, look for adverse effect, and before adding the agent, we have to be very sure that first agent is not acting, and then we change the agents. That's it.
Thank you, Saurabh. Thank you for summarizing so well. So we have 15 minutes, so we can take up the questions, but and also we will listen from the people, those senior people, those who are attending this class. So first question, first you should address this question. Dr. Nandini has asked, what's the evidence of using SSRIs and SNRIs with opioids, which also has those effects in those effects incidence of serotonin syndrome. So can you answer this, Saurabh? Would you like to answer? Or you want to ask Dr. Nandini, can you open your mic and say say a few words of your experience and what exactly you want to know? Nandini?
Yeah. Hi. Very nice, excellent and very clear presentation. Thank you, both Saurabh and Krishnapriya and Dr. Sushma. So my question is especially regarding tapentadol and tramadol, which also have this, serotonin reuptake inhibition and norepinephrine for tapentadol. So I know I have used, I'd say 25 milligrams of tapentadol, in a patient with, say, sertraline already going on for other reasons. And when I looked up the evidence for risk of serotonin toxicity, it says moderate risk for tapentadol and high risk for tramadol. But if you have any direct study, which, if you can elaborate on, because this will be important when we work with other professionals and when we write our drugs, and if we can show very clear evidence, it helps. So that is why this question, especially when we use these drugs along with tramadol and tapentadol. Thanks.
Ma'am, in our practice, we are withholding tramadol if a patient is on tricyclic antidepressants, and we are generally using morphine. So I'll look up the literature. I also could not find any direct study which compares the incidence of serotonin storm with respect to tramadol or tapentadol. But in our setting for cancer pain management, usually we are not going up on tramadol. We generally quickly shift on to morphine. So the combination of tapentadol or tramadol with an SSRI we have rarely seen. I think Dr. Sushma might still elaborate. I'll look for the evidence and I'll still share. I'll make another search.
So I think very relevant question, Nandini, and I don't think that anyone in the anyone must be knowing of this answer, but definitely when patient is so much in pain, I by default I think we start with low dose of morphine, and continuing with in patient with severe pain, I think tramadol, tapentadol, and neuropathy SSRIs. I don't think that. Means like we would have not seen I have not seen any situation like this, but definitely there is a concern about the serotonin about the storm. So I think it's a very relevant question, and this is an area of area of interest, and I think anybody can take up this as a
research topic.
Research topic. Thank you, Nand.
Thank you so much.
Rajshri has an experience of subcutaneous infusion of ketamine. So, Dr. Rajshri, can you open your mic and share, please?
Ma'am, am I audible?
Yeah, you are audible. Yeah.
Ma'am, in Amrita, we have used and we are still using subcutaneous ketamine for resistant neuropathic pain. That means which doesn't respond to our conventional modalities, which are already described. So depending on the patient's tolerance, we have started using like 100 milligram a day as continuous infusions, continuous subcutaneous infusion, and then slowly increasing depending on the pain response as well as from the patient's tolerance. I mean, some patients, they complain of, like a kind of weird sensations like hallucinations and all. If that is not there, we will slowly increase by 100 milligram a day, maximum up to 600 milligram. For one patient, we have gone up to 600 milligram. She got almost 70% pain relief. Then we had been using it as a burst therapy. I mean, when we discharge the patient, on anticonvulsants, if I remember correctly. So we used it for burst therapy only. And one patient said he could not tolerate it beyond 200 or 250 milligram a day. So the responses are quite variable. We cannot get a consistent pattern by using subcutaneous ketamine infusion.
Thank you, Rajshri, for important information. And I think this is true that ketamine, drugs like ketamine, we just cannot rely on for a long-term basis. For short-term basis, we can give pain relief to the patient, but for long-term, we have to think twice that what to do with these medication. And with the oral ketamine and all, you have listened that with 2 studies, there are some good evidence to use, and in 1 study there was of no use. So I think this is again thorough evidence are required in this area also. So before I go to Dr. Vidya, we want to hear from you that what is your recommendation about using what is your say about the neuropathic pain. Before Dr. Vidya starts speaking, I want to ask Saurabh and KP, and you can prepare an answer of that. That have you found, because I know that KP was started preparing this lecture when she was in AIIMS, and that's why I continued Saurabh to moderate this, because she has started, both of them were searching literature, and I think the day we have given this topic, they started preparing this topic. There was a lot of temptation that Naveen can moderate this session, and but I thought that Saurabh and KP were preparing when she was in AIIMS, so we continued this. But KP and Saurabh, I just want to know whether are there any evidence that head-to-head trial of duloxetine versus anticonvulsant or antidepressant. So keep your answer ready till the time we will listen to Dr. Vidya. Dr. Vidya, please open your mic and say.
Good morning, madam. Madam, honestly, I have nothing more to add, because most of our practice is based on the lines that was discussed. So the most common drugs that we use in practice are duloxetine, pregabalin, and gabapentin. And the best part about neuropathic pain is we try and use the medications along with the other symptoms. So suppose a patient has cough and neuropathic pain, then I would prefer gabapentin. Suppose so, if there is a strong element of anxiety and neuropathic pain, then pregabalin would be the choice. So the best part about the medications in neuropathic pain is also the way we combine them for other symptoms. That's all that I wanted to add. Thank you so much for this wonderful presentation.
Thank you, Vidya. So, Shobha, would you like to share your experience about the medication?
Good morning, Sushma. Thank you, and thank you for the excellent presentation, presenter as well as the moderator. So that was very good. I would like to add two things. One is about Nephropam. I think it is a drug that is kind of reinvented in the last decade. Although it is used for nociceptive, like post-operative indication for shivering, for pain, for hiccups. It has definitely a role as an antidepressant because it acts on the descending inhibitory pain pathways and it increases the neurotransmitters that we are interested in, including dopamine. Our experience is that we do give Nephropam for neuropathic pain, and it is available in IV, so that it makes it a suitable drug. If you look at evidence per se, there aren't like any RCTs done on this, and it is from personal experience that we are speaking, both Rajeshri and I. We've used Nephropam just recently, for example, just recently for a patient with an elbow compartment syndrome. And she was on all sorts of medications like duloxetine, pregabalin, tramadol. And she says that, it felt as if her hand is on flames. It's completely burning and things like that. So we introduced Nephropam as IV in the first instance, 20 milligrams IV. And the oral dose of Nephropam is 30 milligrams. So IV, we can go up to 120 milligrams. That's what the literature says. So we gave her 20 milligrams 3 times a day, and her pain subsided considerably is our experience. So it is a good drug to have in your armory. For some patients, it is very effective, but you can't actually predict. And what makes it, efficient is something which we need to look up. I don't know about the genetics or the molecular level at which it acts on. But we do have experience with Nephropam when we, run into a brick wall. That was one thing. Second thing about ketamine, somebody was asking about topical ketamine. We once had a young girl with CRPS who had an injury of her leg because she caught her leg in between a cycle chain, and her pain was continuous for around 2 years, and she went doctor shopping. To a large extent, we could control her pain. We had used ketamine injections into a lignocaine paste. We had mixed it and used it topically. And I don't know whether it was placebo effect or whatever. She had some amount of pain relief with it. And I'm not too sure whether that was the cause for her pain relief or it was something else. So that's our experience of using topical ketamine because it is not available otherwise. So these were the two things that I wanted to add.
Thank you, Shobha. So I think, Saurabh, have you prepared your reply? Yes, Saurabh.
Ma'am, for SNRIs, what we searched, the SNRI duloxetine, it came into recommendation because there was a large RCT with a 5-week use of SNRI duloxetine with placebo, and it for taxane-induced neuropathic pain, chemotherapy with taxane, and it had a positive effect. But there is no trial which has compared SNRIs, the venlafaxine versus duloxetine or other SNRIs to see the superiority among any one of them. With regard to SNRIs compared with SSRIs, I could not find any direct comparison because the dosage SSRIs are usually prescribed in very low doses, and any dose above more than 100 milligrams we require serum levels monitoring. So I'll still search, but for SNRIs, I'm sure that only duloxetine was studied and no intra-SNRI comparison trial has been done. But for SSRI versus SNRI, I'm still not sure.
So thank you, Saurabh. So this is again one very good area of research. So we have only 2 minutes. So I just want to say that thank you very much, KP and Saurabh. And I think your literature search was excellent. Your presentation was too good. And I know that it's going to remain a challenge of treating neuropathic pain, but I would like to add one thing, that even this IASP and all pain organizations are recommending non-pharmacological therapy, which is another, it's a subtopic topic, or probably the next topic it will come. So I think we will continue to use all these medications, but the best thing works with neuropathic pain, with my experience with these medication, is counseling a patient about the pain. So once I know that it is going to be severe, but counseling makes a huge difference. And counseling is going to help in a way when patient will start understanding that this pain is of what type of a nature of this pain, and why this pain is. So once they will start understanding, and what will be the realistic hope possible with any sorts of medication, anticonvulsant, any antidepressant, or uh, duloxetine and whatever, ketamine. So they will make a good baseline expectation. And once the baseline expectation, we all know that when our baseline expectation is low, we feel better. So when they will make a good baseline expectation, that doctor has already explained that this pain is not going to go completely, and if there is the slightest reduction in the pain, patient will feel better. So this is my own experience, that once you will explain this, patient will definitely feel much better. So again, I would like that anybody who wants to explain, so because in the letter, this counseling part should come on the top, because counseling makes a huge difference. It's not only neuropathic pain, but in neuropathic pain, it makes a huge difference. Plus, all these medication works well, duloxetine works well, and all the evidence KP has explained beautifully. And with this, it is 7:30. I want to close with one more comment, that all the residents, those who are joining, MDs and DNB, they are very lucky, and we should thank COVID, who has given us an idea that we can have online classes. And these online classes, the way people are preparing classes, I think it's a huge benefit to all of you. And when we listen to them, I think they search whole lot of literature, and they come with all the important points of that topic in 40 minutes. They finish, and today's is a good example. So Kepi, thank you very much. You have finished in time. There were a lot of time for discussion, and this is an extraordinary presentation. Thank you. Thank you, Nandani, Shobha, Vidya, Rashri, for sharing your experience. And thank you everyone for joining. We'll see you next Monday before 6:30. Please join before 6:30. Thanks a lot.